today. Share the video on YouTube to your colleagues. I'm sure all of them are going to learn a lot with Dr. Anderson the same way that we will learn today. I'm very proud and happy to announce our next big masterclass is going to be this Tuesday, November 17th, at the same time as this meeting today 3 p.m. Rome time. We are going to talk about war zone programs. So it's going to be a very nice session. Dr. Novak is a very well-known cardiac surgeon that does mission trips for kids with heart disease, and he focused in the last years on war zones. So it's going to be very nice to listen to him and to the other speakers to talk about how this is done and how it's possible to help those kids in such difficult situation. This is going to be a combined meeting with the Pan-Arab Congenital Heart Disease Association, and we are going to listen a little bit about how pediatric cardiology has been developed in the Arab countries. So please join us. I'm going to type the link on the chat box. Please join us. It's going to be an amazing meeting. If you have questions to Dr. Anderson, please type on the Q&A chat box. We are going to be very happy to answer all of them in the end of this meeting. Just reminding you that we have a lot of sessions to be done with Dr. Anderson. We are going to cover a lot of very interesting topics. So please join us every Friday at the same time. Thank you, guys. I hope you all enjoy.
Well, good afternoon to you, ladies and gentlemen. Those of you who were with us last week will remember that we discussed Ebstein's malformation. And Ebstein's malformation, of course, is the major congenital lesion that involves the tricuspid valve. Today, I'm going to be discussing with you malformations of the mitral valve. But there are many more variations involving the mitral valve than we find in the setting of the tricuspid valve. So I'm obviously going to be discussing with you the relevant anatomic features. I'm going to base that on the notion of the valvar complex. But those of you who were watching the presentation on Ebstein's malformation will know that in the excellent discussion last week, there were questions asked regarding development. So today, I'm also going to be discussing with you the mechanisms of development of the mitral valve. And as I will show you, many of those mechanisms are equally pertinent in the setting of the tricuspid valve. But the focus of our attention will be the malformations. What I'm going to try to do is to relate the way the valve develops to what you see when the valve is congenitally malformed. But if we are to understand what's going on, of course, we need to understand the normal valve. And the essence of appreciating the anatomy of the normal valve is to analyze it in terms of the valvar complex. Now, this goes back quite a good way, and you see that I'm emphasizing here a work that appeared in 1972 by Joe Perloff, the father of adult congenital heart disease, and Bill Roberts, the consummate pathologist, editor of the American Journal of Cardiology, still, I think, the editor of the American Journal of Cardiology, outstanding cardiac pathologist. And way back there in the 1970s, Bill and Joe together introduced this notion of the valvar complex. And they pointed out that if the valve is to work in harmony, then all parts of the complex need to work together. So what are the components of the valvar complex? Well, the valve starts at the atrioventricular junctions. And in many ways, it would be better if we called this the atrioventricular junctions. But for better or worse, we consider the atrial attachments of the valve as the annulus. The key parts of the valve, of course, are the moving components, and they are the leaflets. Next week, we're going to start discussing the arterial valves, and I'm going to emphasize to you that we can bring understanding between the various valves of the heart by describing the moving components as the leaflets. So today, we'll be looking at the leaflets in the setting of the mitral valve. The key feature of the atrioventricular valvar complex, however, is the presence of tendinous cords, cordi, tendini, if you will. And we need the tendinous cords in the atrioventricular valves because when the valves are closed, they have to withstand the full force of ventricular contraction. So that's why we have the tendinous cords, and the tendinous cords, of course, attach the leaflets to papillary muscles, and the papillary muscles themselves contract to maintain the tension of the leaflets when they are closed during ventricular contraction. So we can see the overall arrangement of the valvar complex very nicely when I show you a simulated parasternal oblique section of the left side of the heart. This is something you see all the time in the echocardiography room, and it shows us very nicely what is going on with the atrioventricular valvar complex. So there you see the attachments of the complex at the atrioventricular junction. And as I say, for better or worse, we're going to call that the annulus. There you see the leaflets, and the leaflets in this particular specimen are shown in their closed position. And you see that the leaflets are then attached by the tendinous cords to papillary muscles, the papillary muscles being anchored at the ventricular myocardium. And the point that Perloff and Roberts made was that if the valve is to work properly, all of these component parts need to be functioning in harmony. But let's look at each separately. We'll start off by analyzing the annulus, and the annulus has two parts. The superior part is fibrous, and this is the area of fibrous continuity between one of the leaflets of the mitral valve and the leaflets of the aortic valve. The other leaflet is attached at the atrioventricular junction, and this is supported throughout its length by the myocardium of the atrial, the ventricular chambers. So we're going to call that the mural leaflet. Now, if we look at a short axis of the valvar complex shown beautifully in this computed tomogram made by my good friend and colleague Tony Levarchek, we're looking up towards the base of the left ventricle from the apex, and they're anchoring the aortic mitral unit in the roof of the left ventricle. We have what we call the fibrous trigones. And there, extending between the fibrous trigones, we have that fibrous part of the so-called annulus. And this is the area of aortic to mitral fibrous continuity. And it is the strongest part of the left atrioventricular junction. If we turn our attention to the mural component of the leaflet, now this is what people expect to see. So there you see a cord-like arrangement of collagen that is supporting the valvar leaflets. And oftentimes this is shown as a complete ring encircling the mural leaflet of the valve. But this is very much the exception rather than the rule. And indeed, if we cut around the entirety of the junction in normal individuals, we find quite some variation. So this is a very nice histologic section made by my good friend and colleague Damian Sanchez Quintana. And it shows you one of the variations, and that is that the leaflet is hinged on top of a fibrous shelf. And you see now that there is a space between the ventricular wall, which you see to your left hand, the insertion of the atrial myocardium that you see to your right hand. And this has received quite some attention recently on the basis of so-called disjunction. Some relate disjunction to mitral valvar prolapse, but in reality, if you look hard, in most normal individuals, you will find some areas where you see this feature known as disjunction. So for me, I still have to be convinced that this has anything to do with pathology, because as I say, if we look hard, we can find arrangements like this in most normal individuals. And if we cut all the way round the hinge of the mural leaflet, the atrioventricular junction, we come across areas like this. Another of the exquisite histologic sections made by Damian Sanchez Quintana. And this time you see that there is only fibroadipose tissue at the atrioventricular junction. And here the leaflet, the mural leaflet of the mitral valve is simply moored at the crest of the ventricular wall. And in many instances, it is the arrangements like this that are the rule rather than the exception. But there is marked variability in the way that the leaflet is hinged at the mural atrioventricular junction. So let's move on from the annulus and let's look at the leaflets. And this is how I look at the leaflets, because here I have opened the left atrioventricular junction. I've made a cut close to the septum, which you see to your right hand, and then I've spread open the atrioventricular junction, moving it towards your left hand. And then you see that one of the leaflets of the valve guards a significantly greater proportion of the overall circumference than does the other leaflet. And this is the mural leaflet. It guards the larger part of the circumference, but it is relatively shallow. And this extends all the way round that mural component of the left atrioventricular junction. So the other leaflet guards a much smaller proportion of the overall circumference, 1/3 about in most instances, but it is much deeper. And this is the leaflet that, when we look at its other side, I'm going to show you a picture of that shortly. This is the one that is in fibrous continuity with the leaflets of the aortic valve. So I call this the aortic leaflet. The other leaflet is the mural leaflet. Many call the leaflet you see to your right hand the anterior leaflet, the other one the posterior leaflet. That is not entirely accurate, but it is the way many still describe the valve. For me, aortic and mural are much more accurate descriptions of what is going on. Now that is how I look at the leaflet, but this is how the leaflet looks like when it's working properly, and this is the surgeon's view of the valve. It's a beautiful picture. It was taken and sent to me a very long time ago by Dr. Van Alistan. I've never met this surgeon, but he was kind enough to send me this picture, and I've used it many times because it shows you the feature of the valve when it is closed. And you note that the solitary zone of apposition between the leaflets of the valve, which you see there, and now I've made this drawing based on that picture I showed you a moment ago, the primary zone of apposition does not reach to the atrioventricular junction. So between the ends of the solitary zone of apposition and the junction, we have these components of the skirt of leaflet tissue. And we call these the commissural leaflets. There are then slits in the mural leaflet. And in most instances, this divides the mural leaflet into 3 components. And we call those 1, 2, 3. This categorization, of course, was introduced by Alain Carpentier, the amazing French surgeon who did so much to bring to the fore repair of the mitral valve. And he called these A1, A2, A3. P1, P2, P3, arguing that they were parts of the posterior leaflet. I like to think of them as M1, M2, M3, mural 1, 2, and 3. The key point they oppose to adjacent areas of the other leaflet. And here we are fortunate because A can stand for either anterior or aortic. This, of course, however, is only the typical arrangement of the mitral valve, and surgeons who operate on the valve will tell you that in many instances there are more slits, and this is no more than a basic arrangement. So we have to take into account the variability depending on the number of slits present in the mural leaflet to permit it to fit snugly against the aortic leaflet. Now I've opened the valve again because I now want to emphasize the tendinous chords. Note again that at the ends of the zone of apposition, the apposition itself does not reach to the atrioventricular junction. So this is the area where we find the commissural leaflets. And then you see there is one particular chord arising from the apex of the papillary muscle that branches to supply both of the adjacent leaflets. These are the so-called commissural chords. The key, the papillary muscles supply both of the leaflets. The other key point, however, is that tendinous chords attach, and they attach to the entirety of the free edge of both leaflets. And this uniform support supplied to the free edges is key to normal function of the valve. I said I'd show you what the ventricular aspect of the leaflet looked like, and this is that aortic leaflet seen from the ventricular aspect. And you see now these thickenings on the ventricular surface, and these are what we call the strut chords, and almost certainly these provide the tension that keeps this leaflet functioning properly when it's in its closed position. If we look under the mural leaflet, we can find still smaller chords, and there you see one, and they have their own little myocardial belly, and these are the basal chords. And to me, if we categorize the tendinous chords in terms of free edge, strut, and basal chords, that is more than enough to explain the way the valve works properly. So the tendinous chords extend from the edge of the leaflet down to the papillary muscles. But how are we properly to describe the papillary muscles? Now here I've opened the heart, or at least I've demonstrated what's going on in the papillary muscles by cutting away the parietal wall of the left ventricle. I haven't opened the heart, but having cut away the parietal wall, I'm showing you the view from the back. And now you see that one of the leaflets is adjacent to the septum, and that is in front of its counterpart, and its counterpart is superiorly located. And I'm showing you this heart more or less in attitudinally fashion, because this is how it lies during life. And we can look at that again in one of Tony Levarchek's exquisite computed tomograms. And this now shows you the short axis. And we now need, or we should be describing these papillary muscles as you see them during life. And now when you do computed tomographic analyses, you can judge the precise positions that these muscles occupy during life, because there we have the compass that's showing what's going on. And if you need more than that, there is the marker that shows you what is posterior. And now if you look at that muscle that is inferiorly located and adjacent to the septum, it's the one to your left hand. If you go to the textbooks, all the time you will see this described as being posteromedial. It is only posteromedial when we take the heart out and sit it on its apex. During life, it is inferoseptal, and the other one is superolateral. And if we are to bring sense to description, that is how we should now be describing them, because that is how you see them when the heart is in the patient. And that is the key. So that is the anatomy of the valvar complex. I'd now like to discuss with you the way it develops, because I do believe that the knowledge of development helps us to understand the lesions I'm eventually going to parade before you. So when we go back to the start of development, we find that the atrioventricular junction is guarded by cushions. And it is these cushions initially that act as valvar entities. They lie within the atrioventricular canal. There is at this early stage atrioventricular canal myocardium. I can show you that very beautifully in this three-dimensional data set prepared by my other good friend and colleague, Tim Mohan. This is prepared using a technique which we call episcopic microscopy. Tim cut the data set from a human embryo, this at Carnegie stage 13, about 5 weeks of development, and he cut it at 1 micron thickness. But then he took photographs of the face of the block as he cut it away. And this then permitted him to reconstruct the overall block with absolute precision. He put it all together, and then we can cut planes through this just as you do with computed tomography or with magnetic resonance imaging, and we can cut it in any plane we want. So here I've taken a cut to show you the atrioventricular canal. And at this early stage of development, the atrioventricular canal is connecting exclusively with the developing left ventricle. We can cut the plane in any way we want. So here I've rotated the cutting plane. And now I'm showing you the long axis of the atrioventricular junction. So there you see the cavity of what will become the left atrium. And the left atrial cavity is in communication with the developing left ventricle. And there now you see the atrioventricular canal myocardium. And within the atrioventricular canal myocardium, lying edge to edge, you see the atrioventricular cushions. And at this early stage, it is these cushions that act as the valve which guards the atrioventricular junction. On top of the developing atrioventricular junction, you see the outflow tract. And within the outflow tract, we have another set of cushions. Next week, we're going to start considering the outflow tract, and I'll show you how these cushions themselves remodel to form the leaflets of the arterial valves. But now we are concerned with what happens to the atrioventricular cushions and to that atrioventricular canal myocardium. At this initial stage, as I've already shown you, the atrioventricular junction connects only to the left ventricle. But very shortly, within a week or so, there has been expansion of the atrioventricular junction. And it is the expansion of the atrioventricular junction that permits the right atrium to look directly into the right ventricle. You can still see the cushions within the atrioventricular canal, but we know that with ongoing development, that atrioventricular canal myocardium will become the vestibules of the atrial chambers, and indeed the break will be between the leading edge, the proximal edge of this atrioventricular canal myocardium and the crest of the ventricular mass. So the vestibules, the atrioventricular canal myocardium, ends up in the atrial chambers. Note that always there is a connection between the left atrium and the left ventricular myocardium. I'm going to emphasize the importance of that as we move on. Now, if we take a heart a little later and we do a dissection, and this was done by my colleagues in Amsterdam using scanning electron microscopy, we can look up at the underside of the atrioventricular junction. And now you see the superior and the inferior atrioventricular cushions, but the canal has expanded. Note, however, that at this stage, the left atrioventricular junction has an obvious trifoliate configuration. This is very reminiscent of what we see in atrioventricular septal defect with common atrioventricular junction. The cushions are separating the junction into the right and left sides. Note that as yet, the outflow tract has yet to bring itself such that the aortic root enters the left ventricle. We'll be discussing that next week. This week, we are concerned with what happens to those cushions. So here, a little later, during that 7th week of development, you see that the right side of the cushions will be part and parcel of the tricuspid valve, but as yet they haven't delaminated. We discussed the importance of delamination in the setting of Ebstein's malformation last week. But look what is happening to those 2 cushions on the left side. They are fusing together, and they will form that aortic leaflet of the mitral valve. But as yet, they have not quite completed their fusion. And that gap between them is also going to be important when we consider malformations. So the 2 major cushions come together and form the aortic leaflet of the valve. As yet, there is minimal formation of the mural leaflet. And indeed, if I take a little later, during that 7th week of development, we see very nicely now that the 2 major cushions have come together. They form the aortic leaflet. But look what is happening to the trabecular part of the ventricular walls. It is compacting to form the papillary muscles. But the point I make here, the myocardium, which you see in purple, is going all the way up to the part developed from the cushions, which you see in blue. As yet, there has been no formation of the tendinous cords. Equally, there still has been minimal formation of the mural leaflet. And all these features are going to be important as we consider the malformations. So at the end of the embryonic period, the 8th week of development, now I'm showing you a cut in the long axis. You see again the aortic leaflet of the valve, and still the compacting papillary muscles go all the way to the margins of the developing leaflets, but still there has been minimal formation of the mural leaflet. And it is not until we get to about 11 or 12 weeks of development, this time a histologic section made again by Damian Sanchez-Quintana, that we can begin to see the valves taking on their postnatal appearance. So now, 1 month after the end of the embryonic period, we see that there has been delamination of the septal leaflet of the tricuspid valve. Note there the atrioventricular conduction axis insulated. There is the aortic leaflet of the mitral valve, formed from those conjoined cushions, and indeed it is the cushions moving over from the left to the right side that are insulating the conduction axis from the atrial myocardium. But now we do have formation of the mural leaflet of the valve, and now we see the beginning of the formation of these tendinous cords between the edges of the cushions that have become the leaflets, the compacting trabeculations that are forming the papillary muscles. A note on the undersurface of that mural leaflet, that tiny compaction producing that little body, which was part and parcel of the basal cord I showed you in that normal mitral valve. So here we are very close to the postnatal situation. I'm going to emphasize these features now as we look at the valve itself. I'm going to emphasize that the major cushions come together to form the aortic leaflet. The lateral cushion appears much later. It eventually delaminates and it forms the mural leaflet. I've shown you that the trabecular layer of the ventricular wall compacts to form the papillary muscles. Importantly, tendinous cords are relatively late in their appearance. So let's now put all of that into the context of malformations. And I've emphasized the complex because on occasion, all parts can be involved: the annulus, the leaflets, tendinous cords, and the papillary muscles. And we see that most typically in the setting of the hypoplastic left heart syndrome. where the left ventricle globally is hyperplastic in the setting of mitral stenosis. So this is shot an example. You can see that the junction is hypoplastic. The leaflets are formed but dysplastic. There has been very little separation of the tendinous cords, and this is thickening of what we call the interchordal spaces. The papillary muscles are formed, but they are involved with the fibroelastotic layer, which is part and parcel of what we see in hyperplastic left heart syndrome with mitral stenosis. So there is overall malformation, abnormality of the mitral valvar complex. But now we can take apart the way the lesions affect the mitral valve, and we can look at that in terms of the complex. So we're going to start by looking at the junction. And the obvious malformation of the junction is when it is absent. It can be guarded by an imperforate valve, but I'm going to show you that in the setting of leaflets. We see absent of the atrioventricular connection most frequently in the setting of hyperplastic left heart syndrome. And indeed, most frequently in mitral atresia, there is absence of that connection. And then, as you know, we looked at this in the setting of the functionally univentricular heart. The left ventricle is no more than a slit in the wall of the valve. And that is what I'm showing you in this 4-chamber cut. This is typical mitral atresia in the setting of hyperplastic left heart syndrome. The right ventricle is dominant. There is the left atrium, and seemingly there is absence of the left atrioventricular connection. The left ventricle is slit-like, but we can find it by dissecting between the delimiting coronary arteries. And then, having found the cavity, the slit-like cavity of the left ventricle, there it is, there is no fibroelastosis, because for the larger part of fetal life, there has been no blood going into and out of this cavity. There is the circumflex artery that is guarding the left atrioventricular junction, but here is a significant point, because when I look into the floor of the left atrium in this setting, I can see an atretic vestibule, and that tells us that initially there was a connection present, and I emphasize to you that from the outset, the left atrial wall was connected to the left ventricular wall, so there was initially a communication between the left atrium and the left ventricle. That has become obliterated during fetal life, because I emphasize to you hyperplastic left heart syndrome is an acquired disease of fetal life. And this is the worst form, mitral atresia, mitral and aortic atresia. And we know that this represents the insult having happened very early during fetal life. We can, however, also have absence of the left atrioventricular connection, as you see there, with a ventricular septal defect. So here the left ventricle is incomplete, right ventricle is dominant, but the aorta now is patent and is arising from the incomplete left ventricle. So this is what we can call mitral atresia with patent aortic root. We can find it with concordant ventricular arterial connections, as I've just shown you. And then there is a ventricular septal defect. And this is the key difference between hyperplastic left heart syndrome, because for me to have hyperplastic left heart syndrome, we need an intact ventricular septum. But we can also have mitral atresia with patent aortic root, and the aorta is arising along with the pulmonary trunk from the right ventricle. And then we have this other interesting combination, but we have to question whether this is mitral or tricuspid atresia. So let me show you this variant. This is what the right side of the heart looks like. The blood is coming from the right atrium through the right atrioventricular valve into a dominant ventricle, but this time the dominant ventricle has left ventricular apical trabeculations, and it supports the pulmonary trunk. the blood is going leftwards through this ventricular septal defect, and here on the anterior and leftward superior shoulder of the heart, we find the incomplete right ventricle, and it is supporting the aorta. But then the blood is coming into this incomplete right ventricle through the ventricular septal defect because there is no way out of the left atrium other than across the atrial septum. Again, however, we have an atretic vestibule in the floor of the left atrium. And this, of course, is what many would call tricuspid atresia. And that is because it was absence of left atrioventricular connection with left-handed ventricular topology. Had the valve been formed, it would have been a morphologically tricuspid valve. And that is also important when we consider another of the malformations of the so-called annulus, and that is Ebstein's malformation. Because Ebstein's malformation on the left side of the heart, when it involves the mitral valve, is exceedingly rare. In most instances, Ebstein's malformation, seen on the left side, is involving the morphologically tricuspid valve in the setting of congenitally corrected transposition. But it is possible to have Ebstein's malformation of the morphologically mitral valve. And here is such an example. I've opened here the left atrioventricular junction, and you will note that the leaflet to the front is deep. It's guarding 1/3 of the junction because this is the aortic leaflet of the mitral valve. And it is now the mural leaflet that is involved in Ebstein's malformation. And that is because with the mitral valve, it is the mural leaflet that is delaminated from the parietal wall of the left ventricle. And in this instance, there is the atrioventricular junction, and the mural leaflet has not delaminated. You can see all the way around, the mural leaflet retains its attachment to the ventricular wall. This is that very rare entity, Ebstein's malformation of the morphologically mitral valve. But most of the lesions involving the mitral valve impact on the leaflets. So I'm now going to show you a series of malformations that can involve the leaflets. We're going to start off by looking at the leaflets when they are imperforate. I'm going to show you the features of the isolated cleft. The leaflets can straddle an override. That obviously also involves the papillary muscles. The leaflets can be divided, even in the left ventricle, to give dual orifice. Significantly, they can prolapse. Now, we've already talked about the imperforate valve because we see that most frequently as part of the hyperplastic left heart syndrome. But we can find it when there are concordant atrioventricular connections or with double outlet. But here you see an imperforate leaflet, and this is in the setting of the hyperplastic left heart syndrome. It's supported by a papillary muscle. Again, because no blood has got into the left ventricle, there is no fibroelastosis. So moving on, this is the cleft, and there it is. And it is the space between the components that come together to form the aortic leaflet of the valve. In this instance, it's coexisting with a ventricular septal defect, but the key, because the atrioventricular junctions have separated, the cleft is pointing into the subaortic outflow tract, differentiating it from the zone of apposition we see in atrioventricular septal defect with common junction, which still many will call a cleft. In this instance, however, when we're looking at the otherwise normal mitral valve, this truly is a cleft in the anterior leaflet, and you can understand why it should come about, because I've shown you how the two cushions come together normally to form the aortic leaflet. This is a pretty picture showing you straddling and overriding, this in the setting of double outlet right ventricle with subpulmonary interventricular communication. And this time I am showing you dual orifices within the mitral valve. And this is the consequence of a connecting tongue between the aortic and the mural leaflet. And now we do have separate orifices, each of the orifices supported by the two papillary muscles, the paired papillary muscles within the left ventricle. Now this is an exquisite picture because this is showing you prolapse of one of the scallops of the leaflet. And prolapse is also important in the adult population because we see prolapse most frequently in the setting of Barlow's syndrome, and then we talk about floppy leaflets. So this is what those floppy leaflets look like. All of them are involved, and this is myxomatous degeneration of the tissue making up the leaflet. Now we're still looking for the reason why we have prolapse, and this is where disjunction has reared its ugly head again. But as I've shown you, disjunction, in fact, is part and parcel of the normal arrangement. So for me, if we're going to look for the mechanism of prolapse, we should be looking much more at the significance of chordal support. Because a very long time ago now, my very good friend and colleague, Anton Becker, with who I did most of my early work, showed that lack of uniform support along the free edge of the leaflets predisposes to prolapse. And I believe that has received insufficient attention. So let's go back to this picture, which in fact was taken by Anton. And there you see again the prolapsing scallop and the feature. There is lack of chordal support along the overall extent. So there is elongation of the tendinous cords, one of which is ruptured. And I do believe that chordal support is a key feature as one of the mechanisms of prolapse, equally as important as so-called disjunction, and perhaps even more so. But they are both variations in the arrangement of the normal valves. So let's finish by looking at the papillary muscles. And here we have two lesions to consider, the arcade or the hammock lesion and the parachute malformation. So here is the key feature of the arcade or the hammock lesion. And that is that the papillary muscles come together and they fuse along the leading edge of the leaflets, and there are no interchordal spaces. But it's now very easy to understand how this comes about because I've shown you that initially the coalescing trabeculations come together and they themselves are directly attached to the leading edge of the leaflets developing the cushions. So we can see that if there is inappropriate remodeling of this junction, we're going to get this arcade or hammock lesion. So this is the parachute lesion. And in this instance, because of fusion of the papillary muscles, again with thickening of the tendinous cords, but there is another variant, and that is when one of the papillary muscles has failed to fuse. So in this instance, all the cords are coming together to the inferoseptal muscle. I said fused a moment ago, I meant failed to form, because in this instance, there has been no formation of the superolateral muscle. So this is the other variant of the so-called parachute malformation. So what I hope I've shown you is that all components of the complex can be congenitally malformed. They can do that together so as to give us global involvement, as I showed you in hypoplastic left heart syndrome, or the malformations can exist in isolation. So that is why I think it makes sense to look at these malformations in terms of the valvar complex. But what I particularly hope I've shown you this week is that when we understand the way these components come together during embryonic development, that gives us a scaffold in which we can build our understanding not only of the normal valve, but the many lesions that can produce malformations of the mitral valve.
Amazing talk as usual, Dr. Anderson. Thank you very much for that. And we are very happy to have you. We only have one question today on the Q&A box. Guys, please don't be shy. This talk was very nice. And I'm sure there are a lot of things that we want to make it deeper and use the knowledge of Dr. Anderson for that. So someone is saying that just to be sure, is it not possible to have abstent malformation of the aortic leaflet of the mitral valve?
Well, the aortic leaflet of the mitral valve, as I've shown you, is itself derived from fusion of the two major cushions. So we get Ebstein's malformation when the leaflets fail to delaminate, but there's nothing for those major cushions to delaminate from. So I showed you some very pretty pictures showing you the developing heart, and those two major cushions are in the roof of the developing left ventricle from the outset. So we're not going to see the variations there that we find with the mural leaflet. It's the mural leaflet, and I showed you also that the cushion in the mural leaflet itself is very late in its development. The expansion of the mural leaflet is also very late. And then in order to form that mural leaflet, it has to delaminate away from the surface of the parietal wall of the left ventricle. And so in a way, that is the key difference between Ebstein's malformation of the mitral valve as opposed to the Ebstenoid malformation of the tricuspid valve in the setting of discordant atrioventricular connections, congenitally corrected transposition. Because in congenitally corrected transposition, it is the septal leaflet that fails to delaminate. And it's the anterosuperior leaflet in the setting of Ebstein's malformation with discordant atrioventricular connections or in the regular situation that retains its attachment at the atrioventricular junctions. In fact, it's very rare when you have Ebstein's malformation for all of the leaflets to have their hinge line displaced apically. I've seen a couple of hearts in regular Ebstein's malformation in which the anterosuperior leaflet does have minimal displacement along the supraventricular crest, but that is exceedingly rare. And as we discussed last week, the feature of the anterosuperior leaflet in Ebstein's malformation is that it is hinged from the atrioventricular junction. And indeed, it is that leaflet that the surgeon most of the time uses when he or she is creating the cone. And you'll remember last week, we discussed how the surgeon now makes a cone out of the leaflets that are present in the setting of Ebstein's malformation. But most of the time, when we have Ebstein's malformation of the tricuspid valve, it is that anterosuperior leaflet that forms the larger part of what the surgeon will create. If you have those very rare situations in the setting of Ebstein's malformation of the mitral valve, and they are exceedingly rare. I think throughout my career, I've only ever seen 2 or 3 examples. In fact, I'd forgotten about the one I showed you today until I was preparing my talk, and there I came across it in my talk. The other interesting feature of it was that it was an imperforate Ebstein's malformation of the mitral valve, but it's possible that the surgeon might have been able to create a cone out of that tissue and could have repaired that Ebstein's malformation of the mitral valve. But again, it is the mural leaflet that is involved when it is the mitral valve. It is the anterosuperior leaflet that is involved with tricuspid valve. And if you have Ebstein's malformation of the mitral valve, it would be the aortic leaflet that doesn't show the evidence of delamination that is present from the outset.
We have a lot of questions now. I'm very happy for that. Thank you guys for participating. Renari Ibrahim is asking about the difference between parachute and hammock mitral valve, as in both the papillary muscles are fused.
Well, it's a very good point. The parachute valve is fusion at the distal end of the papillary muscles, and they come together. And it's interesting that you have these 2 variants of the parachute lesion. The one where the muscles are fused together. And to me, that looks much more like a parachute. Although my very good friend Chark Abel said nobody would want to go out of an airplane with a parachute like that because of the orifice. So the dome of the parachute would not be very good. But it's what we call it. The other variant, to my mind, is rarer, where one of the papillary muscles has failed to fuse. But the problem there reflects the fact that the problem is at the distal end of the papillary muscles. The parachute, sorry, the arcade lesion is at the proximal end of the leaflet where the tendinous cords have failed to fuse. And I showed, I think, very nicely that normally the tendinous cords form at that proximal junction between the papillary muscles and the developing leaflets. And if those tendinous cords fail to form, then you will have that muscle running all the way along the edge of the leaflet. And it's a good point that's made, because those muscular arcade does indeed fuse along the leading edge of the leaflet. So the parachute has fusion at the ventricular end. The arcade or the hammock lesion is myocardialization and fusion at the atrial end of the papillary muscles. It's a very good question.
There's a question asking if it's possible to have arcade and parachute at the same time.
Another very good question. I've never seen it. I think if you had both at the same time, odds on the valve would be, I suppose, in hyperplastic left heart, where you have the global malformation of the leaflet, I guess that is getting towards, in the more severe cases, that is towards the case where you have myocardialization of the whole extent of the tension apparatus and involved with the papillary muscles also fused. But I can't say I've ever seen a case that has not had hyperplastic left heart where they coexist, but I guess it is possible. I mean, when people know these things, they can start looking for them now. And this is the beauty of the questions that are being posed to us. These are the things that we haven't seen yet. If you start looking for them, you may well find them.
This is very nice. And Abdel Fattah Abu is asking about which one is the most common cause of congenital mitral stenosis.
Very difficult for me to answer that. You have to be very suspicious when morphologists start telling you what is the most frequent lesion, because we always see the worst end of any lesion. And the one we see most frequently, of course, is the global involvement in the setting of hyperplastic left heart syndrome. But even there, these days, because of the therapeutic options, the fact you can do the Norwood sequence, you can convert to the Fontan procedure, there are fewer and fewer of even these hearts coming into the autopsy collections. It's very difficult to put to give an estimation of frequency based on what I see. I think the Melbourne group have done a colossal amount of work with repairing and describing mitral valve malformations. They had a paper recently in the European Journal of Cardiothoracic Surgery. I can't remember what the precise incidence of things were in the Melbourne group, but they've written a lot about the mitral valve. So I think that if you look into Yves Dudicam was leading it then, although he's now moved to Washington, but Igor Konstantinov has written a lot about this. And I think if you look into the work that they've produced on the mitral valve, they probably give incidence of the malformations in the clinical setting. But I do think you have to look at it in the clinical setting. I've simply described to you the catalog of what you might expect. I think you need to look at it in your own setting to work out which is most frequent.
We have a couple of questions asking about supravalvar mitral ring and the Schoen complex.
Well, the supravalvar ring, that's another very good question. I should have included that in my presentation, because there can be an involvement of a ring within the funnel of the mitral valve, and that is indeed a malformation of the leaflets. And that's a very good question. I should have included that, because there are two variants, because that, in fact, it's not supravalvar, it is intravalvar. valvar. And that to me is the commonest variant when you have the ring of leaflet tissue, which is narrowing the funnel of the valvar leaflet within the cone of the valve itself. You can also have the proper supravalvar ring. That is a problem of the vestibule. And that's another interesting point. I could have made that point because I showed you that the atrioventricular canal myocardium is sequestrated within the atrial chambers, and on the mitral side, it becomes the vestibule of the left atrium. And that is where you get the true supravalvar shelf. I don't think it's a membrane. I don't think people should be thinking. I think membrane is a terrible term. My good friend Jane Somerville made comments about the membrane, which I won't repeat because they're not really fit for a mixed audience. But the things that we see in the left atrium are true shelves. They produce diaphragmatic type lesions. They are rare. The lesion that is often called supravalve, which is really an intravalvar lesion, is within the skirt of the leaflet tissue, the cone of the leaflet tissue. A good question about Schoen's complex. Schoen's complex, of course, is when we have in combination these lesions that involve the left atrioventricular junction. So one of those is the supravalvar ring, the true supravalvar ring. The second in the Schoen complex is lesions of the leaflets themselves. The third part of the Schoen complex is the subaortic shelf. We're going to discuss that in 2 weeks' time when we talk about subvalvar, valvar, and supravalvar stenosis of the arterial valve, the aortic valve. And then the fourth component of the Schoen complex is coarctation. Of course, whenever we have narrowing of the left ventricular outflow tract with concordant ventricular arterial connections, we should be anticipating coarctation. And my good friend Richard Van Prague had a very nice aphorism. Whenever you have interruption or coarctation, you should always be looking within the ventricle because, as Richard said, all the woe lies below. And so that is one of the combinations of the Schoen complex, the four described by Schoen himself, who was working with Jesse Edwards at the time. He was a Canadian pediatric cardiologist. He returned to Canada. I think he was from Newfoundland. I'm not sure about that. I know he returned and he practiced in Canada. He wrote the description of the complex when he was working with Jesse Edwards. Jesse Edwards by then had moved to Twin Cities. So they were in Minneapolis, St. Paul. And they wrote this very nice account of the lesions, I think in the mid-1960s. And so we call it the Schoen complex. It's exceedingly rare to have all four of these together. The Melbourne group have also published on this quite recently. And they've pointed out that you never get all four together, but that is the Schoen complex. It's the combination of these lesions, but they involve not only the mitral valve, they also involve the outflow tract, and beyond the outflow tract, they also involve the extrapericardial aortic pathways, which we will also be discussing.
Great. There are some questions about mitral valve cleft. Other than in the setting of AVSD.
So what is the question? I mean, you've said it all, that the mitral valve cleft is discrete from atrioventricular septal defect. Increasingly now, it's encouraging to see that people are no longer talking about the lesion you see in atrioventricular septal defect as a cleft, or if they do, they put it in inverted commas. There is an analogy between the two, of course, because they both reflect the fact that the two components that in the mitral valve come together to form the aortic leaflet are also separate in atrioventricular septal defect, but then they are part of the bridging leaflets. And the difference, of course, is that in atrioventricular septal defect, there has been no separation of the atrioventricular junctions. And it is only when you have separation of the atrioventricular junctions to form right and left atrioventricular junctions, then the two components of the atrioventricular cushions come together to form the aortic leaflet of the mitral valve. And that is why When it is a mitral valve, the cleft points into the subaortic outflow tract. When you have common atrioventricular junction, of course, the two components are still bridging the septum, as the cushions do during development. So in atrioventricular septal defect, the zone of apposition, and it is then a zone of apposition rather than a cleft, because it's part of the left atrioventricular valvar orifice. The zone of apposition is pointing towards the ventricular septum, and that is the key difference between the two.
Perfect. And Mariam is asking about the difference between duplicate mitral valve and double orifice mitral valve.
Well, they are probably one and the same, because the interesting thing there, and it was the picture I showed you of the dual orifice, was another of the beautiful pictures taken by Anton Becker. And in that picture, you could see that the orifice, there were tendinous cords all the way around the two orifices. And when you have that situation, the tendinous cords each go to their own papillary muscle. And this is a key difference when the mitral valve is working properly. The papillary muscle supports the opposing leaflets. Here, when you have separation, and it's a good point, in fact, because not always do you have the tendinous cords going down to their own papillary muscles. You can simply have a little tongue of tissue joining the two leaflets together without the formation quite so much of those separate orifices. So I suppose it's a gradation in the extent of separation of the funnel of the atrioventricular valvar leaflet tissue down to its paired papillary muscles.
We have one kind of a surgical question that I found interesting. Jason 10 is saying that in the setting of mitral cleft, frequently there are accessory chordae to outflow tract. Are these chords important for competence of the valve, or can it be sacrificed during surgery?
Now, that's a very good question, and that struck me when I showed you the picture that the picture I used was one with a ventricular septal defect, and I think it is the case that you only get those tendinous cords attaching the leaflets to the crest of the septum when you have the isolated cleft associated. And so I suppose then we shouldn't call it isolated because it's with a ventricular septal defect. You can indeed have clefting of the aortic leaflet with an intact ventricular septum, and then the tendinous cords go to the two papillary muscles. So it's an interesting question that is asked, because typically when you do have the clefting associated with the ventricular septal defect, then as the questioner says, you typically have tendinous cords that attach the edges of the cleft leaflet to the crest of the ventricular septum. I guess you have to divide them. And I think if you left them behind there, you wouldn't be able to get an adequate reapposition of the two edges of the leaflets. But I think that this is something that surgeons will work out what's happening.
Sasha, are you around?
Is Sasha with us, or is he going to do something else? There he is. Yes, Sasha. What about when you get the tendinous cords with an isolated cleft?
No, the idea is sometimes where is to not close completely the cleft, and you can leave because sometimes you can create subaortics, it means the outflow tract can be very small. So in few cases, probably we prefer, if there is this type of lesion, to do not close. It depends on the time of surgery. Of course, it's 4 months. You can also think, do not close it completely, the cleft.
But we're not talking about AVSD now, Sasha. We're talking about regular VSD with a cleft in the aortic leaflet of the mitral valve.
Ah,
It's a mitral valve, not a trifoliate valve.
Ah, okay. So the idea, we close it.
And you would take away any superficial
yes,
cords, and you wouldn't worry about them.
We do peeling, of course. We try to find, yes, we try to find if there is an area to remove, and we do peeling of the valve, yes.
Because I suppose one of the problems there is that if you do have a true mitral valve and you have the clefting of the aortic leaflet, you're not going to have the strut chords. And I get,
Yeah.
would you create any strut chords or anything? Or
Yes, I think that, of course, Bob, you know, it depends case by case. The first idea is depend of what age you are going to operate this patient. The other things is if there is a place to remove, you can do completely and perfect peeling. Of course, there is a risk to create a fragile native mitral valve, but at the same time, you can support with some, how do you say, artificial cord,
yeah,
if you want to add in this case. But I think that as first, you have to try to remove the peeling the valve.
right.
This is something that I like and makes sense.
Okay, thank you.
No, it's a pleasure.
Thank you, Sasha. We have two last questions. One is about if there's possible to have only mitral regurgitation without stenosis on parachute mitral valve.
A good question again. I didn't touch upon mitral regurgitation because I can't say I've ever seen a heart in which there is isolated mitral regurgitation. I mean, in the Carpentier classification, his surgical classification gives you stenosis, regurgitation combined. I mean, the typical, correct me if I'm wrong, Sasha, but the typical form of regurgitation is prolapse, is it not?
Yes, is it? Of course.
So, and if the valve is and I suppose you do have instances where there's both combined regurgitation and prolapse?
Yes. Sometimes you have mostly of the case is losing the coaptation, and the risk is that the A2, P2, the middle part of the mitral valve is not collapse, is not working together.
Coapting, yeah.
Yes, coaptation, yes. This is the most common, I think, combined pathological system that create insufficiency.
Okay, and still talking about insufficiency, Miguel is asking, how is mitral valve involvement in severe insufficiency in pathological anatomy due to dilated cardiomyopathy as opposed to isolated congenital mitral valve regurgitation?
Can I answer? Can I do?
Indeed, I'm glad I hope you can, because I can't answer that one.
No, as probably I know that Miguel is every time with us. Probably is very, he takes attention. So in the mitral of dilated cardiomyopathy is a very different, is a specific disease where the annulus became big, very big. So the distance, the coaptation depth of the mitral valve is very poor. So in this case, we use a ring. In this case, we use we think to reduce the annuloplasty. Generally we do annuloplasty, or sometimes in Italy we use Alfieri stitch when the valve is so big to it doesn't make coaptation. Of course, in different pathologies, I think that surgery of the mitral valve is like a woman, someone like blonde, someone like Grace, it means everybody try to keep some commissuroplasty, some the same things, but I think that surgeon can build within himself what he consider the most important strategy. So for dilated cardiomyopathy, for sure, annuloplasty plus additional Alfieri stitch. But I think that for different pathologies and in order to prevent insufficiency, the strategy is based on personal experience with the mitral valve. In Italy, we say that the mitral valve is the proof of the existence of God. Tricuspid valve is the existence of evil. Because mitral valve is some valve that answer every time to the plastic. If you can work on the mitral valve. As we learn from the cone operation or from the Epstein, tricuspid valve, it's very sometimes impossible to have a normal function. So I think mitral valve, the French school also in Europe made a lot of things for this, is a very accessible valve for repair.
And do you think that the use of echo in the OR changed the way you approach to these corrections?
I think that in the current era, 3D echo, intraoperative echo is the basic to approach a mitral valve. Generally, we do transthoracic, but before in the operating theater, we do a planning with the cardiologist, with the continuous monitoring of the mitral valve. I think that sometimes post-operative, you have to accept some residual lesion. It depends on the case, or a VSD, because sometimes the quality of the valve, the complexity of the disease can make it very difficult.
And is that, do you use transesophageal echo there, Sasha?
Yes, we do transesophageal, and now we are moving very fast to 3D echo, because in adult, Bob, the results are amazing. With the 3D echo intraoperative, they are able to planning fantastic operation.
But is that 3D surface through with on the surface of the heart?
Yes, we have the opportunity to using 3D transesophageal or up to 3.5 kilograms, baby. And I think that this is the way how to approach a mitral valve. And again, mitral valve is every time a good.
And presumably, and if you're doing it with transesophageal or with your 3D, you do that before you come out of the operating room. You make sure the valve is working competently.
Yes, no chance, because again, now with the transesophageal, you are able to bring a patient very stable. I know for the ICU people, and no surprise, because of course mitral valve can change in 1 minute.
Absolutely,
it depends on the preload, afterload. So also the the joint strategy together with anesthetist, the intensivist, it's very important. Of course, cardiologist. Because the mitral valve, it depends on the size of the ventricle, make a lot of change during and of course, use of adrenaline for mitral plasty is something that is not good. Yeah. But the pressure is like the anesthesiologists love pressure, cardiologists love echo, surgeon love valve.
And we all love women.
Yes.
Guys, thank you very much. It was really a very nice session as usual. I hope, thank you very much, Dr. Anderson. And we missed Dr. Norman today. I hope he can join us next week. And thank you, Sasha. Thank you, Dr. Anderson. And guys, please join us on Tuesday on the PANARAB joint webinar